Hi, good evening, everyone. This is Dr. John Santana.
Dr. Rob Farhat.
Thanks for joining us in our webinar tonight. We're going to be talking about pain treatments and on what we do here at the Michigan Center for Pain Management to give you guys an idea of what we can offer you for your symptoms.
Absolutely. First, I want to make sure everyone has the phone number. So the Michigan Center for Pain Management, 248-293-1905, 248-293-1905.
So our clinic is brand new for pain management, but we've been practicing pain management for over 13 years now, 14 years now. And between the three of us, that's a lot of years. So probably 30 plus years combined experience. So we've been doing pain management, is what we trained in, and we wanted to offer this to our patients here in our new office.
Yeah, so folks that have had treatment before, they might be familiar with some of these treatments we offer, but this is for folks that may have not been exposed to some of the options that are available for pain management.
Yeah.
Most of the time people think about pain is usually back pain, which is the number one reason for pain, but that doesn't exclude neck pain, generalized arthritis, knees, hips, shoulders, etc. Even carpal tunnel syndrome, the basic things like tendinitis, we can treat.
So with pain, we treat the whole gamut of pain, like Dr. Farhat was talking about. So there's different treatments that we offer. We're going to focus primarily on the interventional treatments for pain. There's some clinics that offer more medication management, more counseling type stuff for pain. In our office, we focus more on how to first diagnose your pain properly so we can treat it appropriately too.
Yeah. So, one of the things I'm always kind of a stickler about is trying to figure out what's the source of pain. Sometimes we can figure it out, sometimes not, but we're going to try. For instance, if someone's having back pain, it could be their first episode, it could be their 10th episode, and there's a variety of treatments we can offer. First, we start with basic treatments. If patients haven't had any treatment, rest, anti-inflammatories, physical therapy. If those things don't help, then we look at some of these interventional options, so injections to treat or diagnose what the potential source of symptoms are. So things people have heard of but maybe not completely understand what they are. For instance, most people have heard of an epidural steroid injection. So epidural steroid injection is an injection of cortisone or steroids into the space of the spine that houses the nerves of the spine. So people have a pinched nerve, something that's radiating down their leg, the old term sciatica we use. That's usually what the epidural steroid injection for. And that goes for the neck too. So if somebody has a pinched nerve in the neck, it's radiating down their arm, it doesn't get better with conservative treatment. We can inject steroid in the neck or the spine, low back, to treat the symptoms.
Yeah, it's funny too. Is classically, we talk about radiculopathies as having more pain in the extremities more than the spine itself.
Right.
So it can present like that. So it's good that we have experience in spines and shoulders and knees and every other parts of the body that we're able to figure out where it's all coming from. Like Dr. Farhat says, most of the pain complaints that we see is from back pain and neck pain. The epidural injection is one of the primary treatments that we do for that particular pain, where it's pain going down the arms or the legs. It's a really good treatment where it can give patients a lot of relief, usually for a few months. So it's for some patients, that's a good option to stay away from surgery, is that they do these injections 2 or 3 times a year, and that's enough for them to get back to their activities to do what we need to do. There's other spine treatments that we do primarily now for if the pain is just in the back or just in the neck and it's not traveling to your arms or your legs. So that tells me it's not a nerve that's involved. For those type of injections, we do something called a medial branch block or a facet block. If you look at your spine, it's made up of different segments, bones stacked one on top of the other with the discs in between. Sometimes the issue is just arthritis and degeneration in those segments. So we have this technique where we do this injection with the X-ray. So it's a very safe injection. We block the segments that go, the nerves that give sensation to those segments in that part of your spine, where we're able to identify and treat the problem. So the nice thing about the blocks is that it's both diagnostic and therapeutic. So that means that when we inject it, diagnostically we're able to identify the area that you have where the pain is generated from, and it's therapeutic because we go ahead and relieve the pain that way. So it's a nice way of kind of fixing it and also looking at it too. And then depends on typically it's a test, so it only lasts for a short time. Usually I tell my patient it doesn't last longer than 1 or 2 weeks. But during those few days to few weeks that you have this medicine in, it should be really significantly improved. And if it does, we can do something called a radio frequency ablation.
Right.
Go over that.
So the idea is that when we do these test shots, these medial branch blocks that Dr. Sanahan was talking about, we are targeting these nerves that control just the arthritic component of your back, not the nerve that goes down your leg. We get a good response to the test shot. Then we do a procedure where we place a probe or a different type of needle and heat up that probe and try to cook that nerve away so you can get prolonged relief. So instead of a day or a few weeks, we're talking about months of benefit at a time. So this radiofrequency ablation or neurotomy can last up to months at a time. We can do this at every aspect of the spine. But first, it does require the test shots, usually 2 test shots that respond appropriately, reach a certain category, and then we move to the next step. For that radiofrequency, we can sedate people for that procedure, so it's not so uncomfortable. But some people, plenty of people have done it without sedation.
Yep. And it's one of these treatments that typically would last around 18 months, a year and a half, sometimes 8 months to a year. Usually is how it lasts, and then we could always repeat it again. So I've had patients where we would do it once a year, and we kind of do it for long term, and it's enough for them to get back to their activities, go back to work, be able to do the things they need to do. So I really like that treatment as well.
Yeah. The treatments we're talking about are all treating symptoms of the pain. A lot of times people have this idea that things need to be fixed if something is broken or not working appropriately, but a lot of times we just need the body to recover from its injury and you can function. So that's what we're looking for. Sometimes a fix is not the best option. That means surgery of some type, and most people don't want an operation. And unfortunately, sometimes those operations don't always alleviate the patient's pain. So we have these other treatments. Even if somebody has surgery, we do have something called a spinal cord stimulator, which is an implantable device for folks that have chronic pain that have failed the other more conservative injection therapies. This is a device essentially that tries to alter the signal of pain that's going from the periphery of the body to the brain. It's an electrical wires that are placed along the spinal cord and essentially disrupt that nerve signal. We do a test run. We trial it where we place these leads in the spine to give the idea of what it would feel like if the device was permanently implanted. But it's only for a week. The battery that helps the device function stays on the outside. After a week, you come back and we take it out and we decide whether or not it's good enough to implant permanently to try to give patients long-term benefits. It comes with a remote control. Some of these stimulators even have an app on your phone that you can use versus a peripheral stimulator. So there are some long-term options for chronic pain too.
Yeah. So I think the stimulator is one of those things that I like to offer my patients, because if you've tried a lot of things like Dr. Farhat said, even surgeries, it's another treatment that we could do that's not as invasive as surgery, but can be really, really effective. And it's one of those things where, like you said, you can essentially give it a test drive, and before you commit to anything. So it'll give you a glimpse of how it could be before that procedure.
There's not a lot of options in life, let alone medicine, to offer a trial run on things. So that's always an option for folks.
Yeah. And then another pain generator that we see for the lower back would be something coming from your SI joints or your sacroiliac joint. So it's a very good mimicker of low back pain issues, because the symptoms can be very similar to a back pain issue from your spine, but it's exactly not in the spine. So your SI joint or sacroiliac joint is a joint where your pelvis meets your spine. It's a very common area of pain for some patients. It's one of those things that you find with a really good physical examination and getting a good history from our patients, and then we're able to tease out whether the pain is coming from that joint or is it coming from your spine itself. And there are treatments that we do for that. So we do these cortisone injections into that joint also. It's a very thin joint space, but again, we guide the needle with the x-ray or in some cases with the ultrasound. We're able to get into that joint space and put a cortisone injection on there, which relieves the pain pretty drastically and immediately for a lot of patients. Some patients, if they benefit well with the steroid injection, but it only lasts them, let's say, a few months, we have the option of doing a radio frequency ablation too, similar to how we do it on the spine. And again, that usually gives you 8 months to a year of relief for that.
So yeah, statistically speaking, SI joint pain is usually about 1 in 5 patients that have chronic low back pain. Usually can be from a trauma. Now, if somebody has surgery or a fusion, the SI joint pain dramatically escalates. Sometimes can reach 50% of the time, and people still have back pain after low back surgery. So like Dr. Santana said, we do cortisone shots, test injections to verify the source of the pain. If the cortisone injection works long term, we can repeat that for an appropriate number of months. There's a radio frequency, just like we talked about for the spine. There's also SI joint fusion, which is another option for folks that have chronic SI joint pain. So again, it's one of these where we test the injection, verify that it's the right response. If people get the correct response, then we can put a prosthetic device that either separates the joint or completely fuses the joint together to solidify it so it won't move, theoretically, because it's moving too much. So those are all options that we have for patients with chronic low back.
Yeah, and all these are minimally invasive, so there's no overnight hospital. You're usually in and out of the procedure room fairly quickly, and the recovery is pretty quick with that too. And with any type of treatments that we do for the spine, a lot of times we would bundle that with physical therapy, referrals, and things like that, only because, as Dr. Farhat says, a lot of times the pain that we're trying to treat is just enough to block that pain for a segment so that you should be able to, your body can recover. And part of that recovery is getting your mechanics back, to get your strength back, so that you can go on and continue living.
Yeah, we should have prefaced this statement by talking about the basic treatments for musculoskeletal issues: rest, ice, anti-inflammatories, physical therapy. But usually by the time they get to the specialist, they've tried those things, or at least tried a few things on their own, even sometimes a chiropractor as well, or an osteopathic treatment. So most of the things we're talking about are more of the injection therapy options.
Yeah.
Outside of the spine, right? So other options for the spine, we can quickly talk about some more advanced procedures for very specific issues, such as a kyphoplasty. So this is usually from an acute standpoint, a compression fracture in the spine. Most of the time it's elderly folks with osteoporosis, but it could be from a trauma, car accident that doesn't get treated immediately from the emergency room. That can be treated here as well. Essentially, a balloon that's placed into the fractured bone, you inflate it and then you fill it with cement to try to stabilize that fracture. Usually works pretty immediately.
Yeah.
Right? It's essentially people wake up from the procedure and have complete relief from the compression fracture.
Yep. Again, that's also a quick outpatient procedure. Works really well and rather quickly. So it's one of those very satisfying treatments to do, not just for patients, but for us as well. What else do we have?
Last thing for the spine is the discectomy.
Okay. Yeah.
So folks that have a small disc herniation, where it's essentially compressing the nerve root, say we did the epidural steroid injections, relieve the pain in the leg for a short period of time, and it keeps returning. The herniation is not big enough for, say, an open operation or a surgical operation. So there's a percutaneous option for folks where small or larger needle, a small tube essentially placed into the disc material to try to decompress it. So removing some of the disc to shrink up the herniation and take the pressure off the nerve. Usually for folks that have smaller disc herniations, sometimes that's the needed criteria, but sometimes it's worth considering if they're looking at a larger open operation.
Yeah, or like somebody who has, let's say, an annular tear in the disc. Right. A lot of times you see that on the MRI, that kind of weakens the integrity of the disc, causes it to bulge more. So the percutaneous discectomy is a really good treatment for that. And again, it's one of those things that after we do the procedure, most patients will tell, as soon as that inflammation subsides from the procedure, that the pain that they get typically for the legs also improves dramatically. So it's another very satisfying procedure to do. So a lot of these procedures that we talked about with the spine are something that we do here in the office. Everything's done through a needle and through the x-ray. So it's minimally invasive. The recovery is a lot faster because there's no big incisions. And then you're out of the procedure room usually within an hour or so. And a lot of times when we do these procedures, there's really not a lot of indications for restrictions and things like that. But if we do talk to you about that. But a lot of times, most of these procedures you can follow up with physical therapy, and it works really well for it.
So a couple other things we want to talk about as far as say people have arthritic type pain. So shoulders, hips, knees, ankles, wrists. They've tried more conservative treatment, physical therapy. Sometimes chiropractors work on joints, osteopathic doctors do, but we also treat those things such as corticosteroid injections. Sometimes there are those radiofrequency treatments for the peripheral joints, the knee mostly, but there's some other treatment options you can consider if those things aren't always long-term.
Yeah. So a lot of times, again, same thing, we do these injections under image guidance. So there's a lot of important structures in there, nerves and tendons, and blood vessels that we want to make sure we don't get into when we do these injections. But by doing that, we're able to deliver the anesthetic and the steroid right in those areas, whatever joint it is. And again, it gives a lot of good relief in those types of cases.
And sometimes, again, we use it for diagnostic purposes too. So to verify the symptoms are coming from the peripheral joint versus the spine. Sometimes people need to get a quick injection before they're going on a trip to get their pain relief functional so they can sort of have that treatment long term if they needed a knee replacement, a hip replacement, or something like that. So the idea is we're trying to make people functional from their pain.
Yep. And then I just wanted to add to, like I said, a patient that had an issue with a hip pain. So for the longest time, like you kind of knew, he came to me, doc, I have this hip pain on the side. Every time I stand, it hurts. So it kind of like did an exam, nothing really is kind of jumping at me. We did an x-ray of the hip. The hip's not too bad. Some arthritis there, but not to the degree that he was talking about. So we ended up doing just a test block into the joints with an injection on there just to see if it's going to relieve this pain. So unfortunately, it did not relieve this pain. So by doing that test block, I was able to focus the search for the pain to find a different diagnosis. In his case, it was actually occurring from the lower back. So his pain was all here in this hip, but the pain generator was coming from the back. By just doing that diagnostic injection, we're able to drive to the main source of the issue and actually treat that problem. And he's doing much better because of that.
Exactly. So sometimes that's what these injections try to differentiate with potential pain generators.
Yeah. So
sometimes surgeons will send us folks to differentiate. If they're going to do a spine surgery on somebody and they want to make sure it's not their shoulder, so we treat the shoulder, etc., or vice versa, whatever the case may be. So that's why sometimes these injections can be diagnostic as well as therapeutic.
Yeah, and speaking of surgeons, let's say somebody has had a knee replacement or a shoulder replacement, or they've had surgeries in these joints before, and the pain is still persistent. We could do a peripheral nerve stimulator, kind of similar to a spinal cord stimulator, but this one's directed at the nerves of the joint. And the idea is we're using this device to block the nerve that's transmitting pain from those specific joints. So those kinds of cases are really neat because somebody's had, let's say, a knee replacement already but continues to have knee pain. There's really not a lot of options for patients who continue to have those symptoms, but a peripheral nerve stimulator can be an effective way to treat it. So is there anything else from the treatments.
So
This was like a very broad brushstroke on the treatments that we do. These are not just all the treatments that we do. We do a lot of other treatments as well. But what we do is try to give you guys an introduction of the things that we can do and what our approaches is for treating pain. Pain can be a difficult thing to address, but having a partnership between physician and patients, usually we're able to kind of get you at least comfortable and doing better than you were before.
Absolutely. Our goal is to make you functional.
Okay.
Please come see us at the Michigan Center for Pain Management. Phone number 248-293-1905. Thank you.
Okay. Thank you. Have a good night.